and welcome to our 70th International Conference on Rail. I'm honored to be here and join this great event. My sincere gratitude to the Rail President, Professor Salah, and Vice President, Professor Ali, for their continuous support. My deepest appreciation to our legend and pioneer, Dr. Professor Tariq for giving me this chance and the privilege to share this stage with you. Warm greetings to all my chairpersons. Uncovering the role of inflammation in keratoconus. Definitions, as we all know, non-inflammatory progressive condition in which the cornea gets thinner. Clinical features contributing to visual impairment as irregular astigmatism, corneal scarring, sensitivity to light. Inflammation occurs when the body releases chemicals, fighting off or healing damaged tissue. Two hypotheses here, molecular and mechanical, is very important regarding the etiology. Genetic associated general conditions as Down syndrome, connective tissue disorders as Marfan syndrome, sleeping apneas, mechanical mainly in atopic patients and allergic patients through eye rubbing. Etiology, moreover, contains and includes congenital weakness of the cornea, secondary following trauma, or moral changes. So, as a redefinition, consider the concept of keeping the already demonstrated involvement of inflammatory mediators as we can dig through this session. Pathophysiology of keratoconus classified as a non-inflammatory, as we said in the first slide. Condition may be no longer adequate. Continuous keratoconus could be an inflammatory disorder. As we all know, historically, worldwide estimate is 1 in every 2,000 people. Prevalence in Egypt 1.12, Africa at 1.6. The majority in the Middle East and Asian population up to 15%, 30% for adult population, and now we're close to in the whole population to 1.38 to 55 per 1,000, highlighting the need for targeting epidemiological status. Identifying the risk factors is very important, and the interplay between keratoconus and inflammation to identify potential therapeutic targets and improve the patient outcome with the early detection, halting the disease progression, maintaining visual correction with contact lenses, and prevent more aggressive treatments. Relative risk factors increases and times. 1.9 multiplies for the asthma patients, 1.4 multiplies for the allergic patients, and 3 times for the eczema patients. IgE is the core of the pathophysiology. Subclinical and clinical could have it. It binds through specific receptors on the mast cells on the ocular surface, reducing the itch mediators and the inflammatory molecules, recruiting more and more pro-inflammatory molecules as histamine, which is the main concept of the vasodilatation of the blood vessels and the itching and the rubbing issue. Interleukins 1, 2, 4, 5, 6, tumor necrosis, alpha, not only but also beta, affecting increase of the pro-inflammatory and dysregulation of the matrix metalloproteinases, especially type 9. So the role of allergy in vernal keratoconus is very important. Corneal topography patterns are more abnormal. Although allergy will not hasten the keratoconus, but definitely increases the complication, especially the corneal hydrops. Patients of keratoconus who had vernal keratoconus require corneal transplant earlier. So atopic ocular allergy and vernal keratoconus, why it's linked to keratoconus? Through eye rubbing, it's the main core. It is a frequent behavior, not only through this, but due to eye irritation, torsion, eye dryness, motion stress. 3 times of the people who had eye rubbing on daily basis have 50% of architectural corneal changes. Atopy and allergy are the most prevalent risk factors. It is a very important pathway through microtrauma and by the pro-inflammatory cytokines. The impact is chronic inflammation, and that causes a collagen disorganization, progression of keratoconus, and worsen the visual consequences. Complication includes scarring hydrops up to vision loss. Therapeutic approaches here is very important. Simple as conventional and contact lens, more aggressive as surgical, cross-linking and transplant, and a future perspective, which is the immunotherapy, gene therapy, and stem cell therapy. Regarding that, immunotherapy is the only treatment that interferes with the mechanism of allergic diseases. So the immunotherapy. In Rio, we have a large allergy unit performing skin prick test, which is the primary method for diagnosis of immunoglobulin E mediated allergy, considered the gold standard. high sensitivity, easy to perform, clear demonstration, and low cost, rapidly done. Local conjunctival immunotherapy as eye drops for treatment of patients with allergic conjunctivitis have been used in the region since 2000 for the first time in Egypt. By desensitization and applying increased doses of the positive specific known allergens prepared from the natural foods in our allergy lab at Rayo, it decreases the symptoms and signs not only, but creating tolerance. In addition to the anti-inflammatory mediators specific to antihistaminics, lifestyle modification is very important, avoiding the known specific allergens, role of nutrition by using the antioxidants. What about the fourth head box protein? It is a kind of transcription factor that regulates the apoptosis and cell regulation, has an association between corneal thickness, decreases the collagen fibronectin. So multiple molecule drugs targeting the FOXO3 specific reported to have a potential treatment, a kind and a new line of gene therapy. Patient education and empowering this is very important through the whole disease. Case studies. Many case studies have done. 2022, 2023, 2024, investigating and evaluating the role of inflammation in keratoconus. Not only this, but also creating and evaluating methods to downregulate these inflammatory molecules. In Rio, there is an ongoing study evaluating the role of inflammation in keratoconus, and the extent of the increase was found to be associated with the severity and the staging as well. The take-home message here is the inflammation is very crucial in the role of pathogenesis, disease progression, and treatment. Control of inflammation by reducing the IRABL may offer best means. Future studies are to evaluate the cost-effective and allergy units incorporation. Immunotherapy is the gold standard nowadays, and gene therapy. Thank you so much for your attention.